Hi, this is the recording for NSG3009 Health Assessment Study Guide for test number 3. Test number 3 will cover chapters 5 through 7, 18 through 20, and 23. The first question on the study guide: know how the aging process affects the parameters of the mental status. Well, the aging process leaves the parameters of the mental status mostly intact. General knowledge does not decrease, and little or no loss in vocabulary occurs. Response time is slower than in a youth. It takes a little longer for the brain to process information and to react to it. Recent memory, which requires some processing, is somewhat decreasing or decreased when a person ages, but remote memory is not affected at all. Question number 2, know when it's appropriate to complete a complete mental status examination. Usually you perform a complete mental status examination when any abnormality in the person's affect, like how they act, or their behaviors are discovered. And a lot of times too, family members are often let you know about a person's behavioral changes. For instance, like they may have memory loss or any type of inappropriate social interaction, or after a trauma, such as a head injury. That's when it's appropriate to complete a complete mental status examination, not just a test. Be able to assess cognitive function and orientation through the course of the interview. Generally, the nurse can discern the orientation of cognitive function through the course of the interview. And sometimes even the nurse can ask, directly or tactfully. They could say, some people have trouble keeping up with the dates while in the hospital. And then ask them, do you know today's date? And many hospitalized people might often have trouble with the exact date, but they can still be fully oriented on any remaining items that you may ask them. Question number 4, know how to correctly use all facets of the 4 unrelated words tests. The 4 unrelated word tests, generally the person's you can ask questions that usually can be corroborated. So for instance, you can sometimes when person has memory losses, they may often make up answers to fill in the gaps of memory loss. So the 4 unrelated words test basically checks a person's ability to lay down new memories, and it's a pretty highly sensitive and valid memory test. It requires more effort than a person just recalling historic events. So you would generally say, I'm going to say 4 words and I want you to remember them, and then you would say 4 unrelated words, and then you will keep assessing the person, and then a few minutes we'll ask the person to recall the words, and after 5 minutes or so you'll ask for the 4 words. And the normal responses for persons under 60 years of age is accurately stating 3 or 4 words recalls after 5 minutes or 10 minutes or 30 minutes delay. Okay. Let me see. Be able to distinguish between lethargic, stuporous, obtunded, and semi-alert. As we know, a person who is alert is awake and they're readily, easily aroused and they're fully oriented. So for a person to be lethargic, they're not fully alert. They may drift off to sleep when they're not stimulated, but they can't be aroused when they're called upon in a normal voice. And sometimes you would say they look drowsy. But they, at the same time, they may respond to questions appropriately. When a person is in a stupor, for instance, they're spontaneously unconscious. They only respond to persistent and vigorous shaking or pain. They may moan or groan or mumble, and they might still have active reflexes and that type of thing. When a person is obtunded, it's a transitional area between them being lethargic and being stuporous. So they sleep most of the time, they're difficult to arouse, and they need loud and vigorous shaking, and they may act a little bit confused when they're initially aroused. They may converse in what they call monosyllables, like words yes, no, that type of thing, and their speech may be mumbled. So lethargic people can be aroused, they can make sense. Obtunded people are stuporous and one word, syllabus, and it's like that state in between stupor. So stupor, which also some people call a semi-coma, they're very much unconscious. And when they're in a stupor, the only thing that may arouse them is like maybe some really bad pain or something. And they groan and they may what they call moan and that type of thing. Be able to distinguish between aphasias, i.e. global, Broca, Wernicke, and even echolalia. A person, when they have Wernicke's or receptive aphasia, the person can hear sounds and words, but they cannot relate them to any previous experiences. Speech is usually fluent and effortless and well articulated, but it has many paraphasias in it, so they may have word substitutions in when they have Wernicke's or receptive aphasia, or it may be bronch and made up words and that type of thing. Sometimes the speech can also be totally incomprehensible. A person may not even be able to understand their speech pattern. Broca aphasia is a type of expressive aphasia. The person can understand language but cannot express him or herself using language. So they have kind of non-fluent, effortful speech. And they may also be repetitive, and but the auditory and reading comprehensions tend to be pretty much intact. A person that has echolalia. Echolalia is an imitation or the repetition of another person's words or phrases. Also, I do want to throw in there about global aphasia. So that's the most common, and it's also the most severe. Comprehension is absent or reduced, and maybe only to that person's name. And prognosis for language is recovery of language is really, really poor. Spontaneous speech is absent and or reduced as well. So you get it in both areas. Okay. Let's see. No various testing for comprehension in individuals with aphasia. Generally, people with aphasia, you could do additional tests for persons, like mostly word comprehension, how they understand it, asking the individual to point to articles in the room, or asking them to point to parts of their body to see if they even comprehend what you're saying. Also, you can have them read. You can ask a person to read a valuable print, and also you can ask a person to write. Just tell them to write a sentence or something of that type of nature. Okay. No, the number of drinks amounts associated with deaths from cirrhosis and cancer, esophagus problems, and injuries in men. Basically, in men, alcohol consumption, they say of at least 4 standard drinks per day. So 4 standard drinks a day is associated with increased deaths from liver cirrhosis, cancers of the mouth, esophagus, and other areas, and deaths from injuries and other types of causes as well. So those type of things are what's associated with just increased drinking, and I think that you could probably find those type of things in your chapter. I think it's chapter 6. In your chapter 6, as well as knowing the next question. Know the physical effects of cocaine, alcohol, heroin, as well as any type of sedative or users. And the reason why it's important for you to be able to obtain this type of objective data and just have a pretty much of an idea of what you find when a person is using these type of drugs is because it could just kind of give you a overall idea of how the person is looking. So, for instance, if we was just to take the effects of a person using cocaine, and that includes even like if you was to read in your book, even crack cocaine. A person would have a dilated pupil. They'd have tachy or bradycardia, so their heart could be fast or slow. Blood pressure could be elevated or lowered. They'll have sweating, chills, nausea, vomiting, and usually weight loss. They're very euphoric and they're very talkative. They have tactile and visual hallucination, and a lot of times they're hyper, and they have grandiose type behavior. When a person is on alcohol, they usually have unsteady gait, incoordination, nystagmus, and a flushed face. So, and their behavior. People have to realize that alcohol is a sedative. They have dull concentration, impaired judgment, talkativeness, slurred speech, impaired memory. Some people may have irritability or depression. So their moods could go from them being irritable or not irritable. Marijuana, they'll have reddened eyes. They may have a tachycardia, where with cocaine it could go either or. They'll have dry mouth, increased appetite, especially for like junk food, loss of coordination and balance. Usually they'll be euphoric in a pleasant state of relaxation and tranquility. But they do have a slow time perception, impaired judgment, and they can also be suspicious, paranoid, withdrawn, that type of thing as well. And then heroin, did we talk about, I don't know, did we talk about like opiates and heroin and that type of thing? Pinpoint pupils, decreased blood pressure, pulse, respirations, and temperature. So when you talk about morphine, heroin, that type of thing, pain pills, all of that kind of stuff that's in that family. There's slurred speech, lethargy, psychomotor retardation, inattention, impaired judgment, impaired social or occupational functioning. So those type of things. And then when you look at things like people taking amphetamines, it's basically the amphetamines have the same type of reaction as someone that's on cocaine. Review statistics on common illicit substances commonly used in people 12 years old or more. Basically, remember when we was in class and we were discussing about people using marijuana or hashish? Well, I was just saying in person, basically 12 years and older, that was the most commonly used illicit drug that was basically reported. So that's what I really wanted you to take away from that. What physical characteristics would increase the bioavailability of alcohol in the blood for, I guess, like a lower, how can I say it? Where for a longer period of time. So, like, what type of things would be going on with a person that you would think that, okay, these people here particularly, or this type of situation here particularly, would keep the availability of alcohol. So basically their alcohol tolerance is not as high, and it's not cleansing. So if a person has like a decreased liver and or kidney functioning in the blood, the alcohol stays in the blood for longer periods of time. So that is basically what a really affect the overall bioavailability of alcohol in the blood. If the liver and or the kidney is not functioning like it's supposed to be. Know what type of statements would alert the nurse that there is at-risk drinking. Basically, the only thing that I really want you to get away from that is know when a person is telling you something about their drinking, because like you'll tend to ask them questions. Listen for a person. Listen and make sure that that person is telling you, like, they usually say that the guideline is if a person says they have 7 or more drinks a week, or if the person is having 3 or more drinks per occasion, you know, like, so if they sit down for one occasion and they drink and they have 3 or more drinks, that's considered at-risk drinking. So that would alert you that a person, so if they're having more than 7 drinks in a week's period of time, and or if they're having 3 or more drinks at a sitting, that may be a consideration that they're having, they may be at risk or may be alcoholic. A person, just make sure when you talk to the patients, make sure that you give a statement of assistance and concern. And I mean, you know, like really talk to them and sound like you want to assist them and there is some concern about the drinking. You could be concerned, but if you just give them a telephone number or a referral agency, you know, that might not totally be, you know, enough for the individual. Know what types of statement, know what types of actions, okay, that the nurse would take if they was injured, like I just told you. Show the concern and whatnot, and you might need to take some medical steps as far as them being at risk for drinking. Know what types of actions, know the difference between concepts of tolerance, abuse, dependence, and withdrawal. Well, let's start with tolerance. Tolerance is when a person has a substance and they need an increased amount of that substance in order to get the same effect. Like a lot of times people say, well, the more that somebody drinks, the less it has an effect on them. So they're building up tolerance. So they need more to get the same effect they did when they was first ever drank. And they say that that is what a lot of times get people to become addicted, especially if they have an addictive personality, is when they try to use and that type of thing, and then they might feel like they had a fabulous time that time. Then the second time they have to use more or whatever to get the effect they got at the first time. So it's like a vicious cycle. Abuse is when a person needs to use the substance daily in order to function, and they are not able to stop using it. So in order for them to even function, they have to use. So that's the definition of abuse. Dependence is actually physiological. So if they don't use it, they may get sick, and then withdrawal occurs, when a person stops using it. They may go through some type of physiological symptom or whatever. For instance, if a person stops using opiates, such as heroin, they say they go into what might appear to be like having a flu symptoms. And they have dilated pupils, they nose run, they eyes run, they have heart rate starts being tachycardic. So they might have joint hurting and muscle aches and fever and restlessness. All of those are symptoms, from withdrawal. And when you look in your book and you are looking at the symptoms from withdrawal, just take a look at all the little different symptoms, because it seems like a lot of the symptoms are of withdrawal or the opposite of what they call when the person is using. And the only drug that they say that there's no real withdrawal from is marijuana, and they say that's with occasional use. But they say that if a person has chronic or heavy use, they may have sleep disturbances, weight loss, loss of appetite, and sweating, and a little bit of irritability to go along with that. Doing assessment of a client. Okay, so that's it with that. What should be present as a mandatory reporter to notify abuse to, like if a person, we're moving on, from, the drugs, and we're going on to the next, talking about, domestic and, IPV, what type of things what types of let me see. Oops. Oh, that's question number 17. Know when one should assess for IPV or perform a screening. No appropriate screening questions. Basically, many healthcare workers, they tend to feel that there has to be some type of proof before they need to notify or suspect abuse can occur. But, so, for only the suspicion, especially if it's elder or child abuse or neglect, is really necessary in order for you to report to someone. So you don't have to, and that is enough. If you suspect, I've think there's been people who probably had family members. I know my father did it once to his brother, and they fell out for a moment because he didn't feel like he was taking care of his kids the right way at that particular time. So, know how to inform a client that, know when one should assess. Well, okay, when you assess or when you talk to a person about different things, be direct and ask them. Don't ask in a roundabout way. Be direct when you ask about any type of abuse. Know about different conditions and stuff like that. You know, remember we talked about the different type of categories that people have. Like they'll have unintentional abuse, physical neglect may occur and stuff like that, and they might have this good intention. And it's just the failure of the family or caregiver to provide basic goods or services. And they may really truly, but you have to always have good intentions, but you always have to keep the patient at the, their health and welfare at the forefront. Physical abuse is defined as violent acts. So y'all know that, and those that could or result in injury. Financial, we talked about that, about especially like for older people, how like a lot of times you'll have people staying with them and they might not be using their Social Security check to take care of them, or just giving them the basic minimal. And then of course psychological, which people, it results in mental anguish from a person. So just know like the differences between those type of things. A lot of times also sometimes in a lot of assessments they may just routine screen for abuse or intimate partner violence or that type of thing. That has become a part of a lot of places, and like different nursing professional organizations. They have called to basically just assess people for that, because of the fact that, we screen for so many other things. It's okay to ask and screen for that, because it's just become such a common thing out here nowadays. And it's okay to let a person know that it's part of, the regular screening, so they won't think that they're being singled out, or that you're watching them, or nothing like that. When you come and you introduce yourself to a person, you can introduce yourself, and you could say to the person that we're gonna do an examination, especially like if somebody come in, with an injury or something, or anything, or anything like that, it's your responsibility to say that. And then you could just tell them that domestic violence is common, and we need to ask these particular questions, like with everything, So when you getting ready to do a abuse or something like that, assessment for somebody, you could just go ahead on and say, you know, what it is. Okay. So the next question, abrasion, contusion, laceration, and hematoma. I do want you to know when you see those type of injuries and be able to correctly say what those injuries are. For instance, laceration, the word laceration is a tearing or splitting of body tissue. It is usually caused by something like a knife or something. An abrasion is caused by a rubbing of skin or mucous membrane. So, for instance, like if somebody keep rubbing the area, because like me, for instance, I had an area on my hand where I was kind of scratching it, you know, but I didn't really, I don't know if you could call it, it looked more like an abrasion. It wasn't really, it was more like an abrasion, and I was rubbing the skin, and it may have been just like a little bit of breakage, because like sometimes you can even scratch an area and it keeps scratching, and then the next day you look at it and it look like you broke the skin. Or let's say you slipped and you rubbed your skin real hard on a rug, and then the next day you see where that area looked like the skin was almost torn, but maybe a little bit, but quite would not. Well, that's like an abrasion. Then a contusion is injury where you don't have. So a contusion is like if somebody knock you upside your head, and then you bruised up. You know, that's more like a contusion, and it doesn't have a breakage of the skin. So the laceration is the actual splitting or tearing. An abrasion is more like a rubbing injury. A contusion is an injury that might leave a bruise, but you don't have an actual breaking of the skin. And then a hematoma, I know all of y'all have seen where the area is like localized and there's blood up under that has built up under, it's extravasated, extravasated blood that has lifted up under there. That's a hematoma. And then after a while, your body dissolves that blood and it goes down. Okay, let me see. The next question is 20 about the pattern injury. We already discussed that even when we was playing Jeopardy. That's when the object leaves a distinct pattern on the skin. You know, so like you could look at it and say, oh, they did that with a meat pounder, meat grinder, because it has these little things on the end, you know, and then they hit a person and they got them little blocks, or somebody get hit with a belt, and then the belt might have little holes in it, and it might leave a certain type of mark, or it may not, or you know, there are certain things that leave certain types of injuries, and when you look at it and you leave some type of bruise or injury from a particular type of object, that is what is called patterned. Okay. Let me see. As far as for children and that type of thing, I told you that there were certain areas particularly. I just want y'all to know that it's real particular um, make sure that whatever the child says, for instance, let's say you find yourself where you might be like, I think this is abuse. If the child gives you information, make sure you document it just as the child describes how the injury may occur. And then you always have to take into consideration that the abuser may be accompanying the child there at that time. And also, when you looking at a child, they usually, like, okay, when a child bruises over bony prominent areas, like, oh, I hit my elbow, or I fell on my knee, and stuff, and scraped myself, you would probably think that that kind of stuff is kind of normal, because, children run, and they play, and they leap, and they do that stuff. But you have to look at the injuries that are in what they call atypical, so not typical injuries. So if a child has injuries on their buttocks, their hands, their feet, or their stomach, buttocks, hand, feet, or stomach, those areas are rare for a young child, and that should arouse some type of concern. So buttocks, hand, feet, and abdomen. You need to really look at that, and that arouse, some type of concern as far as, know the characteristics. We're going on to the lungs and stuff, and respiratory, know the characteristics of lungs and how to distinguish a normal from abnormal assessment. Normal lungs, basically, well, first, as far as the characteristics of the lungs, we know about the two lobes, right? We know the right has 3 lobes, the left has 2 lobes. The right is longer. The right lung is actually shorter than the left. And then the left lung, and the reason why the right lung is shorter than the left is because of the liver. Right up under the right lung. But it does have more lobes. And the left lung is narrower than the right lung because of the heart bulging to the left. So that's what you need to know about how the lungs actually look. As far as when you're looking at, like, what type of things are normal, I think we talked about that during Jeopardy. Normal lung sound, because when we do our assessments, we want to do symmetric chest, right? What type of sounds? When you percussing in the back, you looking for resonant. You listen to vesicular breath sounds over the peripheral lung fields, muffled voice sounds, and no adventitious sounds. So that's basically when you're just looking at that area. Primary muscles of respirations. The major muscle is the diaphragm. Then you have the intercostal muscles, and that lifts the sternum and elevates the rib during inspiration and stuff, and increases the AP diameter, during that period of time. So those are basically the main muscles, because if you think about expiration, that's primarily passive. You can force a respiration and use other muscles like the accessory neck muscles, the trapezius, the what they call sternomastoid. You can force expiration, and that is with the abdominal muscles, but the major muscle of respiration is diaphragm. Be able to distinguish between tactile fremitus, crepitus, and friction rub. Okay. Usually, let me see. Tactile fremitus. Fremitus is usually more prominent between I guess you could say like around the scapula, as well as around the sternum. Okay, so because that's where generally the major bronchi are closest to the chest wall, and as you go down the chest, you know, fremitus basically decreases. Okay, so I did say, let me look at this study guide. Tactile fremitus, y'all know about that with the 99. Okay, crepitus, it's just a real coarse kind of crackling sensation that's palpable over the skin. And a lot of times they say people got probably emphysema when you hear like the crepitus. And then the pleural friction is inflammation basically of the pleural. And a lot of times I have, like, to tell you really the truth, I haven't ever, I don't know if I've ever heard it, but yeah, a lot of times people say that they've heard it if a person have like atelectasis or something like that going on. So yeah. And let me see. Know the correct method to auscultate. Most of the people that I've discussed different things with, I must have went to the wrong thing. I think I accidentally I think I skipped something. Okay, so basically on 25, question 25, it says know the correct method to auscultate the thorax and the lungs. And the only reason I'm talking about this is because most of the people that I've talked to and that was in with me in lab, I would ask them when they was doing the assessment about how to auscultate the lungs, and you'll look at page 429 of your text, and you see how you going 1, 1, 2, 2, and you going down. Basically what you're doing is you're going from side to side, then you're going down, and then you're going to the other side, down, then to the other side. So the purpose of you doing that is so that you can compare the breath sounds and make sure that they're, you know, the same on each side. Be able to, you know, like recognize sounds that come from somebody who may be potentially asthmatic. Usually a person that is asthmatic, they have usually wheezes or some people call them bronchi, but they usually have wheezes when a person has asthma. Let me see what else I can tell you. I think if I think of something else, I'll let you know. I told you, know the characteristics. Bronchitis, pneumonia, tuberculosis, and pulmonary edema. And basically, when I was going over that, I just kind of thought that that would be something good for you guys to know, because like a person has bronchitis, they usually have a difficulty breathing, and when they do inspiration, that they might have as they're inspiring, they have chest pain, of course pneumonia, you can hear the build up and the crackles. TB, you got people when they have TB, they usually have night sweats. And they'll have a temperature, and you could potentially say that they're having hemoptysis, where they might spit up blood, pulmonary edema. People with pulmonary edema is short of breath. They probably may even have a barrel chest, because it's probably associated with long-term COPD, and that type of thing. Let me see. Oh, know how to describe a normal breath sound. I already told y'all that. And what are adventitious sounds? I told you that. Wheezing, crackles, rhonchi, anything that's not resonance is adventitious. So it's abnormal. Know, be able to distinguish between pericardium, myocardium, endocardium, and the pleural space. Basically, that's just, I think we talked about that when we were talking about the heart, and we got to talking about I'm trying to think if I went into detail with you guys when we was doing Jeopardy. I'm not sure if I did. I'm not sure if I did or not. But well, we could definitely go over that. I could tell you about which each thing is. Okay, we could talk about the pericardium, because we moved on to the heart. Pericardium is, okay, this is how it's described. A tough, fibrous, double-walled sac that surrounds and protects the heart. That's the pericardium. The myocardium is the muscular wall of the heart. and it basically does the pumping. The endocardium is the thin layer of the endothelial tissue that lines the inner surface of the heart. And I think that's it. And that pleural space is the part right there that's like basically, I guess you could say, it's kind of like anchored to the diaphragm. Okay. Know the direction that blood flows. I already went over that. I don't want to keep saying the same things over and over again. But let me see. Remember we talked about the direction of the heart when the direction of the blood flow through the heart. You could just say, okay, just do it quick. Blood, body, if the blood is returning from the body, empties into the right atrium to the right ventricle, and then it goes to the lungs through the pulmonary artery, and then the lungs oxygenate the blood, and then it's returned to the left atrium through the pulmonary vein, and then the blood goes from there to the left ventricle, and then out to the body through the aorta. So that's like, I just want y'all to be able to know just that path. If you could make sure that you know that. We know that the SA node is the pacemaker of the heart. Everybody knows the SA node is the pacemaker of the heart because, okay. Then you got, know the cycle, the electrical stimulus of the heart follows. Know this cycle. Know the SA node near the superior vena cava initiates an electrical response. SA node, superior vena cava. Then the current flows in an orderly sequence. First, it goes across the atria to the AV node in the atrial septum, and it's delayed slightly, allowing the atria a little bit time to contract, and then the ventricles are stimulated, and then the impulse travels to the bundle of his, the right and left bundle branches, and then through ventricles. So SA node, know about the atria at the top, AV node, atrial septum, then you got the ventricles, right? And then through the his, and then the right, left bundle branches, and then through the ventricles like that. Okay, let me see. Okay, know how to assess carotid arteries. Most of us in our lab have talked about that. Someone with carotid, suspected heart disease, they should auscultate each carotid artery for the presence of a bruit. You won't auscultate them at the same time. The nurse should avoid compressing the artery, because if you compress the artery, you might create a false bruit, sound. And then you also, of course, if you're depressed, you're going to compromise the person's circulation. And especially you don't want that to go on if it's narrowed by atherosclerosis already. So basically that's what you do. You're listening for the breathing. You're gonna use you're gonna auscultate using the bell. Okay. Know the difference between modifiable and non-modifiable things as far as the like behaviors and stuff like that. Okay, so like modifiable and modifiable risk factors or behaviors. Oops. I think my little document, you guys. Oh, I'm sorry. Okay. Modifiable. Between modifiable and non-modifiable risk factors for cardiovascular disease. What I want y'all to know when I talk about that is modifiable behaviors or behaviors that you can change. Non-modifiable risk factors for cardiovascular disease or things that you cannot change. Okay. So, for instance, if a person obesity and cigarette smoking, would you call those modifiable or non-modifiable behaviors? Well, of course, they're modifiable. But hereditary and age is basically a non-modifiable risk factors. A sedentary lifestyle is modifiable. So if a person just sit around and crunch on ho-hos all day, that's a modifiable risk factor. You know, you're sedentary. I mean, you can get up and try to do something, you know. So just knowing what the difference of that is all I basically, you know, like kind of wanted y'all to know. I want y'all to know where to palpate the apical impulse. Y'all know where that area is, the PMI, point of maximal endpoint. It's in one intercostal space, the fourth or the fifth. So you're going to do the fourth or fifth intercostal space at the mid-clavicular line. That's where you should be pulsating. Some people call the mid-clavicular line the medial. So when a person asks you if you wanted to touch, and if you were able to touch, and touch a person's area where you might be more likely to palpate, and I'm doing it right now, and I can actually, with my finger, and I can actually feel my heartbeat, and it's at the fourth intercostal space in between the fourth and the fifth. And I went down the mid-clavicular line, which is like, a lot of times it goes like right over the nipple, or to the left just a tad bit to the nipple, and you should be able to palpate there. You can reference page 479 in your text if you have a problem with that. Know the characteristics of the arterial system. I just want y'all to know that the arterial system is a high pressure system because the venous system is not. So know that the most. Know the major artery that supplies blood to the arm and the leg. The brachial artery is, of course, the major artery in the arm. That's what I would pretty much want y'all to know as far as uh uh the arms, because I mean it the brachial artery, like it goes into the two little arteries, like the ulnar and the radial artery, but the brachial artery is probably the best artery as far as or the biggest and most artery that you would want to look at as far as the arm. When you're looking at the legs, you want to look at the probably at the groin area. And I don't know why I've lost my train of thought, but because you got the posterior tibial, and that's between the Achilles, that's at the Achilles tendon. Popliteal is behind the knee. But I don't know why I can't think of the name of the artery, and I'll be telling everybody to palpate it at school, but know that a lot of that major is right there at the but that goes into the lower extremities and stuff, is right, starts generally, at the groin area. And when I think of it, I'll let y'all know, but I know y'all know. So, let me see. I would like for y'all to know, the arteries. And we've been practicing them in lab, just like y'all know, the supply to the foot. On the top of the foot is the dorsal pedis, dorsalis pedis. The popliteal is behind the knee. Posterior tibial behind the Achilles tendon. Those type of areas. So if you know those, the inguinal area has an artery there. Also, yeah, the inguinal. I don't know why I couldn't think of that for the longest. Maybe I've been saying it all day. Let me see what else we got here. So we already talked about the arteries, and we already talked about what the profile sign mean, and you detecting clubbing. We talked about that during Jeopardy. What would the nurse do? If the pulse is like very diminished, well, basically what you would do is you would first want to listen to see if you hear any type of bruit. So you use your stethoscope initially to see if there's a bruit. And the reason why is because if there's a bruit, that means that there is turbulent blood flow. And then that indicates that there's some type of partial occlusion. So like when you first trying to get it, well, it's a good thing to do initially, even before you pull out the ultrasound and that type of thing, and you're trying to look for that. If there's a choice for you to look for like a bruit or something like that prior to if there's a pulse, because it's just saying you did the assessment and you didn't find no pulse. You might have had capillary refill and not had a real good pulse, So, yeah, you need to know what that is, how you would assess, and what that meant. Let me see. Next is if a person has hyperthyroidism, they're going to definitely have a full bounding pulse. Because that, most of the people who have hyperthyroidism and stuff like that, and I think I kind of talked about it, and the thyroid is like the most dangerous, it's just like the most dangerous gland in our body. And when people has hyperthyroidism or Graves' disease, whatever you want to call it, they usually have like a real, like a bounding pulse. I mean, it's not weak, it's just like boom, boom, boom. A lot of times, their apical pulse, sometimes because they lose so much weight, people have said that they've actually seen people with hyperthyroidism where they could literally, it looks like you could literally see the pulse, like bounding out of their chest. What are the physical findings? For instance, if you find somebody with venous stasis, well, first of all, I guess you would probably have to know what venous stasis represents or what it is. Okay, so if a person has venous stasis, which means that the blood is not being carried back to the heart, it's not circulating well. A lot of times, if you look at their the bottom of their legs, a lot of times they'll have like a kind of brown discoloration. And when we get into I look forward to, especially when we go to the nursing homes, to being able to show you guys, because they have what they call hemosiderin deposits, and it's like a byproduct of the red blood cells. And with them sitting there that long, it'll make their legs, like the bottom part of their legs, look brown and discolored. Also, not only will it be like that little brown discoloration, they'll have pallor, sometimes, but more so pallor when the arterial and stuff is not working. So, and cyanosis and that kind of stuff. Or if they have cold, that would be a lot of times when the arterial's not even circulating the blood. So what I would tell you to notice is that the major, when it says venous stasis, where the vein, you're not having that blood flow pump back up, is that brown discoloration that you see. Let me see. Know the symptoms of thrombophlebitis, varicose veins, lymphedema, and Raynaud's phenomenon, which is pretty kind of funny because we've talked about, I think, a series of those type of things since even within the skits, which I found to be pretty amusing. But we will discuss it now. Start with thrombophlebitis. I think I told y'all about thrombophlebitis when we were talking earlier, I told y'all that thrombophlebitis is simply inflammation, right, of the veins, and as a result of the inflammation of the veins, a lot of times people will see that little, I guess you could say it's like a little red streak, and the area will be kind of warm to the touch and stuff like that. So when you see thrombophlebitis, that usually happens. And I told you too that a lot of times that happens as a result of people getting a whole lot of little different treatments and stuff, and as a result of them getting treatments like with antibiotics and stuff like that, that's real caustic. You know, a lot of times you can see that type of thing happen. Also, let me see what else I got. Oh, varicose veins. It's just a result of like incompetent valves in the veins. They're more common in women. And then usually like just the stress and stuff, because a lot of times you'll see people have when they get pregnant, they might get varicose veins, and they usually hurt. A lot of times people say they make their legs more tired. They might make their legs hurt more, you know, and I mean, it could be pretty. I've seen people get them stripped before, or get something. They do something to I guess you could say dissolve them or whatever. I would like for you to read up on Raynaud's and phenomenon. We talked about that a little bit, about the different way that the hands and stuff look, and the different color changes and stuff, and discolorations, and how that look as a result of a person doing quite a few of a lot of little different things, like a big, they might have a strong smoking history or something like that, and lymphedema is usually as a result of really kind of bad flow, and as a result of the flow, a lot of times it's real common in women who have mastectomies, that may have had cancer or something to that, and it looks like the lymphatic ducts and stuff are pretty much damaged, and the lymph nodes and stuff like that, and that's what results, because then the blood is not, or the fluid and stuff like that from the lymph nodes is not being filtered the way it should be, and you'll see them and they'll have like fat hands, flat arms, you know, that type of thing going on. Okay. Talked about that. Okay, and then lastly, when I asked you guys about the parts of the nervous system, I just want y'all to know the two parts, central and peripheral. And y'all should have known that from the when y'all took anatomy. Y'all know the central nervous system and is the brain and the spinal cord. I think that's been beat into our head forever. Let me see. The peripheral nervous system includes 12 cranial nerves that y'all been learning, and the 31 pairs of spinal nerves and all their branches. So all y'all have to know is that it's two parts, the central and the peripheral. The central is the brain and the spinal cord, and then the peripheral is everything else, the cranial nerves, the spinal nerves, and all the branches. Okay. Frontal, occipital, parietal, and temporal lobes of the brain. The frontal lobe is for personality, behavior, emotions, and intellectual. The parietal is mainly just for sensation. The occipital lobe is, let me see, it's responsible for visual and reception, occipital. And then the temporal is for hearing, taste, and smell. Okay. Oh, let me see. No, the function of the hypothalamus, cerebellum, and the basal ganglia. The hypothalamus, body temperature, sleep center, anterior and posterior pituitary gland, and it controls the autonomic nervous system, activity, and emotions. The cerebellum, y'all, mostly for motor coordination. So you're talking about balance, cerebellum. And then the basal ganglia controls the autonomic movements of the body. So those are basically what's going on there. Know the difference between vertigo, syncope, dizziness, and seizure. Vertigo is when a person feel like they spinning, and it's due to some type of neurological dysfunction or a problem with the vestibular apparatus, which is basically the balance. So, you know. Then, let me see, what's the other one? Syncope. Syncope is a sudden loss of strength or a temporary loss of consciousness. So you'll hear people say they passed out and they had a episode of syncope. Dizziness is lightheaded, and usually people say they're having a swimming sensation. Seizures is basically altered loss of consciousness, and involuntary muscle movements and sensory disturbances. So those are the difference between that. Now the cranial nerves. I'm not going to go over all the cranial nerves. That's all we've been going through. Of the nerves, but I will give you a clue. Look at page 646 of your book, because we've been going over cranial nerves over and over. Y'all been getting that in lab. Y'all been getting it everywhere. And I will tell you to look from page 644 to 647. 644 to 647 in your book. And I'm telling you to know the different cranial nerves, because I am going to put one motor component cranial nerve on there, and I want you to know if I describe it should be like real like apparent. And so if I describe a certain action, you should probably know what nerve it is. Okay. And then we know about ataxia. We know about ataxia is swaying. So we got to think about what test do we do. What test is it called? The Romberg test. Remember we tell people to close their eyes and they stay in there and you watch whether or not they're swaying. As far as and so you want to make sure they're not having ataxia, which is an uncoordinated or unsteady gait. Let me see. Homing sign is basically you doing that sign to check for deep vein thrombosis. They really, truly, to tell you the truth, don't too much use that no more. When you bend the like the foot back, you know, by the calf, and to see if whether or not the person is having any pain. That's what it is. Okay. Hyperalgesia, hyperesthesia, and neuropathy. Basically, algesia is when a person is like feeling a lot of I guess you could say pain in the area, and neuropathy is when a person pretty much don't feel they have a problem with feeling anything, especially if they have like peripheral neuropathy, which is really common, and it's really common in people who might have be diabetic or something like that. So like for instance, hyperalgesia is increased pain sensation. So if you was to see, for instance, hypoalgesia, you know that was decreased. Hyperesthesia is like when they touch something, they have a increased touch sensation, but a decreased touch sensation is hypoesthesia. And then they even have anesthesia. That's where you get absent touch sensation. So when you up under anesthesia, you know how you don't sense nothing. That's where they get that from. And then neuropathy, of course, is when a person has some type of nerve or lesion or deficit and sensory loss. I do want you guys to know the difference between all the like different tests and stuff, and you're doing them in class, so I really don't think that you would probably have a problem even remembering like for instance extinction. Extinction, and we're not testing for that, but that's basically when you touch a person's body at the same time and you ask them how many areas were touched. So they may tell you 2, and then you might touch 1 the next time. You see what I'm saying? Or you might touch both sides of the body at the same point and ask them how many sensations are felt. And if it's normal, both, sensations are felt. And then the A stereognosis is when a person cannot identify the actual object. And we do stereognosis test is when the person identifies. So if it's a stereognosis, that means they can't identify the object. Graphesthesia, y'all know about that. Tactile discrimination, them being able to say that something is rough or something is smooth or something like that. And then also the last thing that I would ask you is to make sure that you're very, very, very aware of the Glasgow Coma Scale. And you'll find that on page 673 in your book. But you just, knowing that a person, if they're fully alert, they have a score of 15, whereas a score of, I think it's 7 or less reflects a coma on the scale, So you want to know, just about that range and just take a little glimpse at it. Also, did I tell you, when a person has peripheral neuropathy, like when I was telling you about a person, they don't have, their sense of touch is really, really poor, y'all. The temperature, if something vibrates, they usually have a loss of vibration sense. It's 2. They have to be very, very careful. Did I tell y'all about kinesthesia? I think, was that on my list? Kinesthesia, moving up and down. Remember, position sense. Is it up? Is it down? Is it up? Is it down? Like that kind of stuff. You take that finger. Other than that, I don't think I have no other questions that I probably have not gone over. I think I said, I told y'all about risk factors and that type of thing. Yeah. Okay. So have a good time studying, and everybody take care. Thanks.